I'm doing okay.
Good. That's good. It's Thursday, and we've got a 3-day weekend coming up, so that's always
Yeah,
good.
no, it's exciting times.
Indeed, indeed. Sad about the Queen, obviously.
Yeah,
Moments
no,
of
that is,
sadness.
it is.
Maybe not for you, because
It's not my queen.
Have you got a New Zealand passport?
No, I
Not
don't.
yet. Not yet.
No.
Soon,
The,
not yet.
the Dutch would make me give up my Dutch passport. I'm not quite ready to go there yet.
Oh, really? Would they?
Yeah, yes,
Oh,
they
that's
would.
interesting. So I've got an Irish passport, which is an EU one, and a New Zealand passport. So I got mine for living there. So but they didn't make me give up my New Zealand one.
No, most countries have sort of come to the conclusion that that's not really a great idea if you want to sort of encourage people to work internationally, but
Yeah. Oh well, maybe the Netherlands needs to figure these things out. I'm sure you'll get there. I'm sure you'll get there.
yeah.
Very good. Very good. Well, we're running a little bit early, so
Yeah,
probably have a
no, but I
few
was
more people dial
just
in.
joining the meeting because otherwise I might forget.
Yeah, well, so lots of things have happened since we've last had one of these, so lots of things to update people on, and presumably lots of people have been doing things as well, so I think it's about a month since we last had one of these, so because we had a week, in that same week we did the Hey Soleil.
Hello, John.
This is the international version.
Oh, sorry. I just
This is the international version.
Oops. Can you hear me?
Yeah.
Cool. I just didn't have the mic plug in my computer, which is not quite good.
Yeah, this is the international open mic version.
Yeah, that's right. Open mic version. That's true. So, how many people are waiting for here?
Oh, it is literally an open mic thing. It's like a drop-in thing. So
okay.
You're currently running like a minute early, so people normally start arriving from the hour.
Okay.
And lots of stuff's been happening. So lots of things to talk about. Like I've talked to some people about robots, Soleil. So we need to talk about robots. Yeah.
Oh, that's fantastic. That's great. That's really good. Tomorrow we have I'm going to check out the roadshow here in Canterbury to see what's the Caroline innovation side. I had to look into the inland revenue tax for research and development that they have. The tax that was released in December 2021. So I just had to look into that, and I was just trying to understand a bit more of that because there are some things about the Caroline innovation and some limitations if you have that funds on that. So just
I had never thought of looking at that. But of course, yeah. So as soon as you said it, I was like, holy crap, yeah, that's a great idea. Because that's for the R&D tax credit, isn't it?
Correct. Yeah. So any company that's investing on that side can actually have credits on that, which is but you cannot be receiving any other. There is some restrictions in terms of funding that you're receiving and so on. So the policy is quite interesting. Good, but I'm not an accountant, so I don't really quite understand the ins and outs of that. So I just need to spend some time looking at the guidance document from Inland Revenue, which is great. And then we got the digital strategy, Aotearoa digital strategy released this week as well. And that has some stuff around.
It does, yeah. So that's been a long time coming. So that's kind of been backwards and forwards through a bunch of government kind of processes, central government processes, where kind of you don't want to be committing to things that you can't deliver or outcomes you can't achieve, but at the same time, a digital strategy for the country needs to push the boat out a bit because it's kind of one of those things that if you're not looking to do anything, then nothing will happen. So
yeah, and that's the part. I just haven't really looked through with detail of that. But this probably is not as bold as you would like to see the commitment towards the funding, like you see in Singapore and other governments, really big on that side.
Yeah, so I think there's an interesting kind of question about can you count the things that are already happening, or does the strategy have to be about new things? Because I mean, there are things that are being funded, or there are things that are being explored, and there's kind of this question of, is a strategy to give you more money to do the things you're already doing, or is it to do things you're not doing? Interesting question. And I don't know what the right answer is on any of that stuff, but it's always a question, you know, that kind of, I wonder, better to have a more effort into the problem you're trying to solve, or try and solve another one at the same time.
Yeah, it's quite few priorities. What could it look like in
Oh yeah.
32? I'm not quite sure if you guys have seen it, just but it's quite
quite a lot of stuff. Oh yeah, very good. You put the link in. Excellent.
Yeah, it's quite some flagship, some MAR respirations, which is cool. Some no, that's 3 strategic streams. That's what's
So something that we've done in the last month is we've put up, so we moved to the eHealth forum, which I don't know if you guys necessarily would know that. So I think I've said to you, but you're, so I don't know if you know forum.hinz.org.nz. So we've moved all our stuff that was on Yammer to there. So that's got standards on it now. We're moving the data stuff we do. We've moved our stuff, and then there's kind of clinical informatics people go there. And a part of kind of the stuff that we've done is post up the projects we know people are doing. So we've got a list of 127 things that we know people are working on, and we've got your project, from the for the genomics stuff, and we've got some of the stuff that Michael's told me he's working on. And then as things are coming up, we're just slowly adding them to the list so that we can kind of keep an eye on what's on the list of things and who's doing what, and just so that if you find a project you're interested in, you know who to talk to, and maybe you can collaborate. So that'd be cool. And then Soleil, I've put up the robot thing, but I've also put up wayfinding as a thing as well, because I think underneath the robot thing is that wayfinding conversation to go, do we have 3D models of buildings for lots of reasons, which then one of the use cases is seeing the robot stuff.
Yeah, so, that's the wayfinding would be interesting part as well, and how you stretch that from the community, from patient.
Totally. So my job is to try and get a meeting set up to start talking about the mapping side. And I think I said to you, did I say that to you, that I was going to set up the meeting? But Justin wants to come along, and some of your colleagues are going to come on. So Richard Dean, and some of your colleagues that do the LiDAR 3D model building of the crime scenes. So kind of this question of where we've got older hospitals, how do we build a model of those older hospitals? How do we maintain it, and then what do you use it for? Well, use it for lots of stuff, but you have to have the model first. So,
did you check up the ADHB stuff? The guys.
Yeah. So Justin sent a bunch of stuff through, and kind of we got to the okay. So we think we know that the underlying problem is having a model, especially for lots of the older hospitals we have. And so how do we look at that bit? And then the question is, well, what problem do you pick off if you can make a model? What's the first problem you pick off if you make a model? And so we've kind of got lots of different things at lots of layers that we need to kind of try and start to figure out how we deal with the different layers. So, yeah.
Strategy, right?
Yeah.
It is because it is like a big problem, but it's an awesome problem to solve around that engagement with our communities into our health system. So it's worth getting right, because we hate to make that journey even worse. Through navigating through some other building to get to the point that they want to get to. But
well, and I think the interesting question for us is what's the part of that we should own? Do you know what I mean? And I think the reality is we probably don't want someone else owning the models of our hospitals, probably because it's kind of core, because it probably underpins a bunch of stuff. So, if someone else owns that model, then they might not let us use it for the things we want to use it for. Do you know what I mean? Or they might not let us update it when we want to. So there's kind of that interesting kind of problem of how we manage that as well. And it's not to say you need to own everything, but
it's definitely, especially around that security aspect as well. gaming communities, I've been working in this area quite a lot. They come up with a virtual model, but they obviously, that next step. So they, like you say, they're working in that chunk beyond what the virtual reality is. But how do you navigate people through games?
Yeah.
That's
I hadn't even thought of that, because presumably that's kind of, a big part of the, you think about the games is about, the graphics, and it's about the environment for the game to be set in. But then you're right, you've got this kind of narrative of someone experiencing the game and kind of how you move through that.
Yeah, and that story's important, like especially engaging some of our community. I think.
Yeah,
the story. How do you get there is important.
Yeah. Well, it's you might argue that's the difference between an okay game and a really good game, is one that actually engages the player beyond just either whether it looks good. Do you know what I mean? Like,
did you guys have seen the concept of 4D? I'm just trying to find out the stuff that I sent one off to Tony Lloyd for him to just to have a benchmark about what's actually some stuff is going on around the markets. It's very interesting.
Is that smell-o-vision, Solly?
Sorry?
Is that smell-o-vision? This starting to sound like your work.
It's no, look, I just found those guys. They are from this to develop this the language Modelica, and they actually commercialize one part. It is the open source one of the stuff, but the other part is commercialized. And this and this company has one of the parts showing the 4D part of in the healthcare, and it's just like blows your mind when you look what they are actually doing already. But I was connecting with those guys just to look at the digital twins actually at the tool perspective, not necessary, because you need the whole concept wrap around, but just looking at the concept of digital twin, what's the capability, what has been developed in healthcare, and they haven't come back to me yet with their experience on hospital level care. It looks like they have lots. There was one of the. It's just it's interesting to see what's actually. I mean, we are looking that space because of the facility side for the modular facilities, and looking that side. There are lots of companies. There is one company in New Zealand that they will blow the market away when they actually finish. They are actually as the toy company, the Zuru.
Zuru.
Yes, Zuru. Yeah. So they're doing they are changing the way how you build homes, and they are creating a whole fabric in China with robotics to do the whole from digitalizing from your house, from your computer, to going through doing the whole production planning part through their. Yes, pretty cool stuff.
So your house arrives like in a container at your house, like at your site.
Yeah.
From China.
Yeah. Right. Yeah.
That sounds insane.
Well, there are some houses in Christchurch that actually arrive from China from a container. They are container houses.
Yeah. Oh, yeah.
They are really, but it just took a little bit longer than what people expected about that. So, but yeah. So I thought that's if you guys have a time to have a look in that 3D experience company stuff, it's just for you to see what's going on outside the little New Zealand. Really fascinating.
It's real funny because I was talking to someone earlier today, a journalist for the National Business Review, and the conversation was around the growth of medical technology in New Zealand. And I said, and she was, what are the big barriers? And I said, we tend to be quite insular. She's like, oh yeah, that's true. And I said, it takes either people coming in or going away for a while to come back and say, oh yeah, we are a bit insular. We need to be looking outside what we do. In order to kind of take advantage of what other people have done and stand on their shoulders, basically. I wonder if she thought I was particularly enlightened when I made that comment, because it's not generally something the health system has been that good at historically, I would say. So I don't know what your experience has been, since you've kind of come to New Zealand. How good is New Zealand at looking outside? I don't.
Yeah, that there is a bit of the not invented here syndrome that goes around, and that people want their own system and not wanting to adopt something that is already running for years somewhere else. And the other thing that I think is it's quite fragmented for the population size that you have. Like it's that's to me is still sometimes boggles me. Like then you hear people that are like we were at CoLab. You hear that the digital pathologists they just want to send images of the slides rather than to have to send the slides physically across to the person that's going to interpret it, and that they then hit IT firewalls. And to me, that's just sometimes that, yes.
Yeah, it's funny though, because I spent like 2 hours talking to the City of Frankfurt. Frankfurt, yeah, I think so. Maybe last Tuesday night, and you know, talked them through what we'd done in the COVID response, and they couldn't believe it, because apparently, like, the municipality of Frankfurt's about 5.6 million, so about the same size as our country, and they said, because Germany's a bit weird with their health system. So they've got the federal health system, which is social insurance and then private providers, and then they've got public health, which is tied to the city. They couldn't even get their testing done. They couldn't get their tests from the person through the lab, through the public health people, to know who that person was, and then so that the health system knew that there was someone that had COVID.
Yeah.
And so, and that's just one city, if you know what I mean. So I'm not sure, there's not a geographic thing in this. Do you know what I mean? There's like this question of it being, an organizational thing, or just that what's your focus? Is it an inward focus on what you do, or is it an outward focus on who you can collaborate with? And I kind of wonder how do you build a culture which is, or how do you build kind of people's expectation that they should be looking to other people to help them solve their problem. And it's funny because it kind of got beaten into me when I went to work in Ireland in the private sector. They're like, none of you are very smart. Someone's already done it before. You should be looking at how EY's done it before internationally before you go and try and invent your own way to do something. And of course, that was kind of a risk management approach, which was, why did you do this? Well, it was already done somewhere else, so we just copied what they did, type model. And so that's kind of where it came from for me. But I think, maybe there's the freewheeling nature of how the health system and how New Zealanders think, which is, oh, sure, we've got a problem. I can have a go at that. Do you know what I mean? And so you kind of end up in this situation where, because you've had the idea, you get really attached to the idea, and so you kind of want to own it and progress it. Whereas, maybe that question is, how do you transform that from being kind of that internalized, I've got to solve this problem, to a we've got to solve this problem, how do I share the problem around kind of question?
I think I found it interesting, John, because I was having kind of a similar conversation with my friends. I had some friends from Perth here, and she works in the private sector, very different way world, and we were talking about the capabilities, investments, and everything else, and just throwing some numbers in comparison. And we kind of like, what I arrived in the conclusion, and when I talked to another friend, and she said it's not so easy to understand what's going on here. Literally, New Zealand tried to solve problems because we don't have the money. Every other country has natural resource that they just put a hole in the ground and pull the money out, literally. They don't need to worry about that. New Zealand, we are constrained for financial resource. We don't have money. And by that, people need to do everything in the shoestring or reinvent a different way how to do it. That's why we don't really do that. And then when you start thinking about technology from overseas and so on, the cost of bringing those stuff, people start saying, oh, wow, millions here. We could do that. But then if you think about long term, technically, we need to develop IP in New Zealand. We cannot survive without IP, but actually it's a fine balance how much like those guys in France or whatever in Europe doing some stuff. We need to do the Paraguay version. I'm not sure you have been South America, but Paraguay is the place where you would go there to buy everything that was cheap because everything was kind of like but literally, you would go there and you come back home with a full Nike clothes and everything else, and a few things that looks like real, but actually was made in Paraguay. Even the radio with Paraguay, but you think it's Panasonic, was made in Paraguay. It works really well, perfect. There was no problem about that. But New Zealand needs to be a little bit like a Paraguay, really, because we don't have the money. We just need to make things cheaper and make it work. So I think that's kind of like becomes the. I mean, more I live in New Zealand, more I see that. That's kind of like feels the reality.
Yeah, and I think that's part of it. Like the resourcing is a reason why people then build something themselves. But to me that there is a huge hidden cost to that. Like if we would actually account like what you deliver in terms of healthcare outcomes or otherwise against the full cost of what people are doing sort of underneath their desk or in their shed, like that is a cost, and it's real. And I don't think that as a systems way approach that we've necessarily accounted for that really well previously, and then sort of it's not visible.
Yeah.
On the flip side to that, I think people that dive deeper into the design side of thing or understanding the problem get a better understanding of the problem. So rather than just receiving a product and going, this is how we use it, if you dive into like, well, this is how it's applied and this is how we use it, then there's a greater understanding of the technology, its application, that sort of thing as well. So there's a bit of a catch-22 on that.
I think it's kind of that, where do you add value to this solution? Do you know what I mean? So not assuming that, you can't take, so what can you steal from other people as much as what can you add yourself because you understand the problem? And that was kind of a little bit of the conversation I ended up having with the journalist, was this question of, shouldn't you just be buying things off the shelf, not inventing anything as the health system? And I'm like, well, the problem with that is we're the people that are delivering the care, and now we have the problems. So how do we know that the thing if we're buying something off the shelf, we need to make it fit our problem? And you've got this kind of thing that meets in the middle, which is, if we're solving our problem, how reusable is it? But if we're using someone else's solution, how well does it fit our problem? And so you've kind of got that interface, which is, that assessment of, come back to the 3D maps, what part of it do you own? What's your strategy around what part of the problem are you solving? And is it something that we need to solve, or can we use someone else's kind of solution in that context? And it's a tricky question, I suppose.
My learnings that I had with my past life back in Northland, working across 98 NGOs, my learnings was that actually the system drives the process, and if systems are designed badly, you're going to drive a bad process. And I think the part that Michael mentioned is that the people who are actually doing the stuff know really best the process. But the issue that we have sometimes is that where you have people that knows the stuff are developing system that they don't have the technical capability to do something that's resilient and robust, that actually you can scale up, and then becomes that point of problem. If there is a way of, you have a cluster hub that actually people are thinking about the system, making it work, but you have the people in the background that have seen what's the skeleton of the stuff, make it sufficient, resilient, and scalable, then we would be in a much better picture. I mean, you can see Canterbury, we have so many systems we develop here, and we know some of the issues that we have here, but at the same time that Joep mentioned about the wastage and so on, in some ways for us hasn't been wastage, because we, some stuff are not perfect, but also we have managed to solve some major problems that elsewhere in New Zealand haven't been able to solve yet 10 years later. So it's not perfect, but also it's actually deliver what needs to deliver for the time that we need to deliver. So kind of like it's really tricky balance, really tricky balance.
Oh, you're never going to get it exactly right? That's the other point. Like, as you say, John, but at least let's be conscious about it.
Yeah. That's really fun. I don't know who I was talking to yesterday. Was we had this conversation about, I know. So there's this problem that we've got lots and lots of websites. So as a health system, we've got like over 100 websites or something. And so you've got this question of, how do you offer a better, like in a physical context, that wayfinding thing across all of these websites, where, if you need to get a mammogram, you've got a whole other context to getting bowel screening, or your child has a temperature. Those are all very different things to consumers, and yet you've kind of got this question about, how do we offer a more seamless kind of experience across 90 websites? And then you kind of go, so that's like a visual context for the user, and then you go, well, what's the technological underpinning for that? So how are we offering kind of common components technologically for those services? So login, where you need a login, or the use of a standard type of framework like React or Angular JS or whatever it happens to be. And so that's the second kind of piece to it. And then the third piece was, well, how are we authoring any of this content? So how do we write something for that website which everyone agrees with, might be reusable across 2 or 3 websites, but also for different audiences, a clinical audience different to a consumer audience. And I kind of finished saying this stuff, and there were 30 people in the call, and they were like, oh God, this sounds like insurmountable as a problem. And I'm like, well, maybe, maybe it might be, but that to me is a good understanding of the problem. And so the direction is, how do we solve that? But even just knowing about the fact that those are the problems we need to solve kind of makes you more conscious of how you make those decisions and point in that direction. Not so much a believer in the fact that, you're going to solve all of the problems with this one answer, but you kind of incrementalize your way in the right direction. But you need to know the direction, like, what is the direction? Are we going left or right here? We're going straight up and down, or, sideways. And so knowing that and then slowly moving in that direction gives you kind of time to realize either you're doing the wrong thing, or you could go faster over this bit, or whatever. But it was funny because that's exactly the conversation we had yesterday in that context.
The streamliners have been working on that field for quite some time with the health pathways and the community health pathways and so on, and they moderate the internal stuff between clinicians, but not with the wider public, and that becomes the tricky part, how you moderate the perception and experience from the wider public. So at the moment, if you go in Google, and I remember I used to have we did some initial search here in Canterbury. It was about moderating the Google Maps stuff. We've tried to direct people from the Google side to actually see where is the 24 hours, where is urgent care. Just try to implicitly redirect the public going to those traffic, just using that. But then we also noticed that the whole patient experience, which the ministry pays the primary care with a specific tool to survey, and they keep changing the questions all the time, the Health and Quality Commission. The whole patient experience in Google, no one is moderating that, which is actually where probably people actually think where to go.
So, well, that was something else that came up. It was kind of this, if you're focused on our web properties, you've got this question of how do people even know they exist? So we were busy focused on when people are in our web properties, how do we make that experience better? And I'm like, but how do they even get there in the first instance? Is because someone told me the other week, it's an age thing as to whether you type in URLs or you just search for stuff. And so apparently that's a thing. And so if you're searching for things, you're not going necessarily to our property, you're going wherever the search engine's told you to go. Do you know what I mean? So we're kind of beholden to that, like you're saying, Solly. Like it's not even our control as to what the person's searching for. Like how do we help in that context? Because it's easy to find misinformation. Or just the wrong information. Yeah,
that's right. Some of that problem too, like looking back at like the just navigating here, like looking at some of the evidence around the do not shows, like that's so much waste in the system, around the outpatient appointments. Is looking at, is it access and was why we not got this engagement of, what's those barriers at just getting here? So it's sort of framing up that wider problem. There's some good evidence around stuff already in the system that there's so much waste.
Totally agree, but it's that understanding that your problem is one that other people have had before. So understanding that problem really well, and then going not just how do I solve the problem, but has anyone else solved this problem, and who and how can they help me? Because I think the interesting thing to me is I think we've got the language around the do not shows or the do not attends backwards. Because that should be, what is your clinic attendance rate? And so if you think about the signal that sends, so a do not attend puts the onus on the patient to turn up, which may not be appropriate. It's an externality. It's the patient's fault that they didn't come to the clinic. But if you call it clinic attendance rate, so what's the percentage of people that turned up at your clinic? It's now your problem that your patients aren't turning up at your clinic, and that's the same number. Do you know what I mean? Like 1 minus the number we described before. But it makes for a really different conversation. Hey, only 60% of your patients are coming to your clinic, and 80% of my patients are coming to my clinic. Why is that? Is that because I need to change my practice, or I only do clinics on a Tuesday afternoon because whatever reason? Do you know what I mean? It kind of makes you think in a different way about whose problem is it, I suppose.
Yeah. Good point.
And I think a little bit more further the rhetoric is about the did not attend is interesting part because everyone talks about did not attend. And the question that I have asked some of my colleagues is that, we haven't sequencing the did not attend because the worst appointment people can lose or miss is your first FSA, because if you miss that, your first specialist appointment, you actually delay your treatment for part.
Yeah.
If you miss your last appointment after 3, probably you felt it was not necessary. Even the doctor just did that because probably it was part. So which appointment actually we're missing here? And I would be concerned about the FSA part.
Yeah.
And
totally.
that's the kind of things that for me, when I was in Canterbury, I was working with the Maori group to actually help and then to advocate that part, because in the Maori action plan, it does say it's about did not attend as an action. But I said the problem with that is actually you are actually not actually in the problem. The problem is actually if you're FSA and you're rural and so on, how we solve that problem? How can we understand that we help you to solve that problem? But we're not flagging that in our systems.
But I think all you're saying there, Soleil, kind of backs up this entire conversation we've been having, which is, do you understand the problem you're trying to solve? Because, I don't know, I said this to the journalist as well. There's a quote from Albert Einstein, which was, if you give me an hour to save the world, I'll spend 59 minutes on defining the problem. So, it's that sort of problem-solving mindset, or that curious mindset to go, have I really got this understood? And, kind of coupled with a slightly more incremental view of the world where you don't have to leap to the biggest possible solution tomorrow, lets you experiment and not have a massive failure, I suppose, is kind of the key thing. So, yep, how are you guys getting on with your genomic stuff?
It's progressing. We're getting ready to put something out to the market sooner rather than later. But there's some couple of pieces that, especially with the new data futures and data sovereignty, that we wanted to get really right in terms of the co-governance of that.
Cool.
So that we've been working through that side of things. And we've also been chatting with Roche and their initiative and what they're doing, just to ensure that we're aligning with that as well as what Auckland is planning in the personalized medicine space.
Yeah, so I had someone come and see me from another company, someone like a subsidiary of Medtronic or something, and they were like, and I said, Roche and some of the other companies in New Zealand are trying to set up an equivalent of, is it Ingene or something like that they've got in Australia? And he was like, oh, are they? And I was like, public sector is busy coordinating the private sector there, which is, feels like a bit of a surprise sometimes. Because of course they don't want to tell each other anything because that's competition, so put them in touch with Kate Reed from Deloitte, and hopefully I think it's one of the Medtronic subsidiaries will be a part of that conversation as well, which, it's good for us. The more of this conversation we can aggregate up so that we're not having the same conversation multiple times, I think is good for us. Yeah. I also saw Di Safati the other week, last week, I think, and I said to her around the human genomic side of things, and can we find a cancer use case where we could look at that practical outcome from the sequencing? So you get so normally at the moment you do a sequence and then you get a result which describes the outcome from the sequencing, but it doesn't do that next step which says, so as a consequence of that, this medicine's the best medicine or this medicine's the worst medicine in that context. And so could we kind of do some work in that? And she was quite enthusiastic about that. She was like, oh, but it was quite funny. She was like, do you mean it's that's more my cancer hat? And I was like, no, because we'd need to engage Pharmac in this conversation. And I said, in your current role, you're probably the right person to tell Pharmac that we need to work with them. And she's like, oh, that's a good point. So she was quite enthusiastic about it. So I think there's definitely going to be some interest to move that forward. And then there was a conversation yesterday about it with the minister. So Chris Pritt was at the meeting yesterday with the minister about trying to move it forward as well on the human side. So.
Yeah, no, but I think that those sort of, as you say, those real tangible examples of how it impacts treatment in a positive way is what New Zealand is needing to put that on the agenda. So if we can deliver some of those, we just have to make it happen.
Yeah. Get it done. Put it on the list. Get it done. Yeah, very good, very good. How you doing, Sujan? You well?
Oh, it's all good. Nothing exciting from my side the last 2 weeks, but I was just interested, how did the feedback on your innovation efforts from the HINZ conference go?
It was good. So for those of you that don't know, there was a HINZ leadership summit thingy start of the month, so 4 weeks ago today, I think maybe. And Robin Whittaker and I had to run a table and kind of go through what our operating model around the innovation stuff's going to look like. And so I'm busy telling Michael things he already knows, and probably Ben and Mary. But we've got kind of some plans around what the vision and the mission and the values are going to be. Got a bit of a plan around what we want to ask for money to do. We've got a bit of a plan around working up kind of the innovation pathway, so the pipeline or the pathway or the funnel or whatever you want to call that, how that's going to look. And then there's one for the intervention logic. So how do we measure success? How do we know we're doing the right thing? So we're kind of basically we're asking people for feedback in that space. And it's one of those things that you get a lot of feedback, novel feedback. I think I did the same conversation 10 times. Lots of novel feedback in the first 2 or 3, and then it's that law of diminishing returns where by the time I got to the 10th conversation, I was still hearing the same things, which is good because it kind of suggests that everyone agrees these are the things that you should be focusing on. But at the same time, it starts to get hard because it's kind of that same conversation that you've been over. So essentially, everyone said, yeah, can we be more organized? Can we do more innovation? Can we coordinate it better? How do we grow the capability and capacity of the health system to do it? What training are we offering people? So all of that sort of stuff came up, which was, I suppose, is unsurprising. So that's what we're busy working on. We've since had a meeting with our what we're going to call our National Innovation Network Council. Feel free to tell me you've got a better idea for the name. Feels like a bit of a mouthful at the moment, and that's all of the people that feel like they've got a role in delivering innovation in Te Whatu Ora, and a couple of key partners. And I kind of wonder at how we might include ESR in that conversation as well. So I mean, that's something for you guys to have a think about, come back to me on, because essentially we've got Diana Sue there from a CMDT kind of perspective. We've got I think kind of from a health system perspective, we're also kind of quite a diverse bunch. So Michael's coming along from a bioengineering perspective. We've got Robin Whittaker there, so she's kind of from a clinical perspective. So we're trying to, and then we've got the quality and patient safety people there as well. So we've got quite a mix of people, not just IT people doing IT stuff, which is good. And so the next meeting for that's next Wednesday, and so hopefully just keep moving that forward as a block of stuff, block of work, pretty much. So
yeah, so I've kind of raised this with some of our people within the organization, that how can we work a bit closer in terms of addressing some of the health innovation problems, and there is a bit of interest, but again, the challenge is there's no existing pathways to interact. So that's something I think we have to work together to kind of bring, especially in the data science, genomics, and few other areas which we are keen to get, like a new horizon type projects, get involved in those and try to, see what we can contribute towards the new reforms and towards the new innovation space.
Yeah, 100%.
Definitely there is interest. And one of the things that I was also thinking, John, is perhaps I should invite you for a talk that maybe you should present to ESR some of the challenges that healthcare system is going through and how we can kind of interact. That kind of gives a organization-wide perspective for within ESR.
Yeah. Well, I mean, more than happy to. I don't know if you guys have kind of an all hands kind of like all of ESR meeting ever. Do you guys do that?
We do have like this afternoon.
Yeah, just gonna say the Friday afternoon seminar series, I think would be a good spot for it, Sujan.
Yeah. Well, I mean, definitely bring Robin along. Her and I are kind of joined at the hip on this sort of stuff, so she'll definitely bring a clinical perspective, and she runs the I3 in Waitemata. So, I think more than happy to come along and tell you that we don't have all of the answers, and can you please help us? It's I think that's that. Come back to the original conversation, which was how do we look outside and get help from other people and build partnerships. That's certainly what we need to do, because there's lots of good people out there, and no point in keeping the system fragmented in that way. So yeah. So hey, Mary, have you seen anything on the internet in the last month? I'm sure you have.
I know it does feel like it's been a month. Yes. What did I just spot the other day? FBI has spotlighted the cybersecurity risks with new recommendations about healthcare organisations to address unpatched medical devices, which it says is increasingly being targeted for cyber attacks. So obviously a big thing. So there's issued a report offering recommendations to address the number of vulnerabilities in active medical devices stemming from outdated software, as well as the lack of security features in older hardware. Obviously, a bit of a big deal. Once exploited, they could impact the healthcare facility operations, patient safety, data confidentiality, and data integrity. And they said the ones most vulnerable to cyber attacks were insulin pumps, intracardiac defibs, mobile cardiac telemetry, pacemakers, and pain pumps with a word in front of it that I can't say. So yeah, I thought that was quite interesting. So I can post that up. And so the researchers found that an average of 6.2 vulnerabilities per medical device, and 40% of medical devices at end of life stage offer little to no security patches or upgrades.
That doesn't sound scary at all.
Yeah.
All high risk devices.
Yeah.
For sure.
Yeah, all class 3. Like, it's a real funny thing. So people go, oh, you don't have any regulation of devices in New Zealand. You kind of like, well, even if they're even if they're class 3 devices via the FDA, that doesn't necessarily mean they've been patched, or the vendors offered patches or whatever it is. So it's kind of this really interesting question of sooner or later it's going to become a very big problem, because it'll turn out, I think my view is it'll turn out that most of these attacks are starting to be much more automated and much more mediated by kind of botnets and things like that. And so we're going to end up in a situation where it seems like hackers and the like have kind of avoided hospitals and those sorts of and us because it felt scary and serious. Do you know what I mean? Like, people would hack those devices, but we weren't really exploited as a sector internationally, because that felt like you were going over the line. And I think the reality is, as you automate some of this stuff more, they won't even realise what their botnet's running on necessarily, and it might be an MRI machine in Dunedin Hospital. So they just won't even know. Do you know what I mean? Like, it'll be, the machine said this device has got the right vulnerability and the right amount of network traffic to hide whatever we're going to do with it, and so therefore we're going to use that, and the person won't even know. And so suddenly it'll become fair game almost by default. So no shortage of work for you, Solly.
No, that's but it's so our team is quite small, so probably we'll decline the work because we can't do everything. No, we got some really good people looking at cybersecurity from that and digital, I guess, and that's their responsibility to look into the protocols and everything is working across the facilities.
Yeah, I think I mentioned this maybe the last time we talked, but there's a bit of work going on out of Canterbury University, which is Science for Technology Innovation, so National Science Challenge funded. So this is Louis, and I think Jeff Chase is probably involved, and they're looking to dumb down some of the devices and move some of the sophistication off the device back into kind of edge networks or into the cloud, so that you can kind of protect some of the key functions and some of that kind of risk. Try and simplify it rather than have the complexity running in the devices themselves, which, you know, 6 of one, half a dozen of the other. You know, the dumber the device, the easier maybe it is to take advantage of, but maybe the more transparent it is that it has been. Or so, an interesting kind of question as to whether that's a good strategy or not. Because I just know, you know, the bigger the operating system stack, the more likely it is there's going to be holes in it, and therefore the more likely it is that you've got a hole to take advantage of. So if you try and simplify it down to firmware and network, maybe that's an easier thing to maintain. So I don't know if you guys actively think about that, Mike, whether that's kind of a...
Yeah, we do. Something you need to get better at, like there's, you know, obviously when we're buying an equipment, you need to get, you know, from the 8 ball around procurement, around what's the threats, what's the strategy around buying that stuff in. But yeah, definitely when you're building devices, obviously patient information is one of the things that you protect, and even around that storage. And it's amazing how many products you buy in and that hasn't been thought about, that protection around some of that stuff, and it's an afterthought. I'm just looking at that now for a product, and yeah, it's scary, really. That should be thought about a long time ago. Or that's
we'll worry about it next year. Next year's product, we'll worry about that.
To get it
in the market.
The year 3000. That's when we'll worry about it. When that no, was it 2999 or something?
Yeah. Before we hit the, what is it, the Y3K bug? Yeah, very good. So something else that I've kind of kicked off yesterday, which might be of interest, and I've messaged Michael earlier today to ask him a question, which has come out of some of this conversation. We've been doing work around that home monitoring, and so one of the things we're interested in looking at is how much a phone can do. So a phone is, you know, a thing, and if you add, you know, in a home situation, if you've got a phone, what can that do before you start adding more devices? So generally speaking, our experience is that there are companies that want to sell you like a vertically integrated solution. So they'll sell you the measuring device, so the smart scales. Then they'll sell you the device, which is the gateway to get the data over the internet, and then they'll sell you the platform to put the data on, and then they'll sell you the algorithm that tells the clinician that the weight's gone out of the range that you want it to be in. And then none of that's connected to any systems that we have at the moment anyway. So then you've kind of got the swivel chair between the system you normally use to manage your patients and the system that's doing the alerting. So the question I had, and there's lots of these use cases. So I think we've got something like 25 examples of different types of use cases that you could use remote monitoring for. You know, the latest one was Nelson Marlborough, who were looking for something to measure someone's blood pressure remotely, because at the moment they are giving out chemo, and the chemo that they're giving out results in unstable blood pressure. So they want to monitor someone's blood pressure as they're taking the chemo, and so they're tasking a district nurse to drive out to someone's house to take the blood pressure. And in a rural context, that's, you know, 3 visits a day just to take someone's blood pressure, and you're like, can we do something else? And so what can a phone do? What can a phone do without needing other devices connected? Because you run into this complexity of, you know, if every device we're connecting needs a different way to get on the internet and goes onto a different platform, we end up with lots of platforms and lots of gateways and lots of devices, and none of them talk to each other. So currently just working through a specific use case at the moment. So you might have seen on the news that they've been putting Biobuttons on people that have had COVID in South Canterbury and then in Counties Manukau. So we're looking at whether there's and interestingly enough, there's a product out of Israel, which is an algorithm from a company called Binah. So we've just pushed go on that yesterday to build that into some of the MyCovid record consumer-facing service. So in order to make the Biobutton work, they're busy handing people a phone with the Biobutton. So they have to have a phone to get the data to go on the platform. And we're like, well, could we put MyCovid record on the phone and then allow people to use this Binah thing, which basically collects data from a front-facing video camera on your phone to measure a large number of the same measures as is in the Biobutton, except the data comes straight out of the back of MyCovid record and straight into a set of APIs we've built for care plans and then goes into the system that the clinicians are using to manage those patients at the moment. So it's kind of a we own the middle bit, which is the APIs. The Counties Manukau people are running CCCM, which is an industry product, and the phone is kind of what the phone is, so we don't have to go and get another device, and it's got a camera on it, and the standardization of it helps. So we're doing that. But I was messaging Michael going, hey, so a phone has a camera and we're capturing video at the moment. Could we do like otoscopes, or could we do other things like measuring, voice print? So I was talking to Pfizer on Friday, and they're running a clinical trial in the US where they're using voice print analysis to know whether the person has a respiratory infection. So basically they've got a machine learning model which identifies the difference between a voice that isn't sick and one that has respiratory illness. And so, that's another kind of indicator which you get off the phone rather than having to buy another thing. So that's quite interesting. You're in my head in the surveillance context. So at the moment, we're busy trying to figure out what disease surveillance looks like for COVID, and we're busy trying to convince people that they should go and get tested, and it's really, really hard. And the response rate's really, really low. And I kind of wonder whether something like that would be a really novel screening technique to go, hey, your voice sounds funny, maybe you should go and get a test, or your voice sounds fine, can you go and get a test to check that it is? And you might engage people through like a novel thing like that, maybe. I don't know.
Yeah, no, it is. It's interesting to see sort of how different sort of health-based things are trying to use also the smartwatches, right? It's again a demographic which it's easy to reach probably because they're sort of technically clued in, but for those people that have that, what can you offer? I think the comment that was made earlier is that those rural settings, that's the much harder part, right? So to focus on, like, even if that means just shipping out phones, like, is that the best thing that we can do? And what do we then get out of it?
Yeah,
in terms of
totally.
health outcomes.
But so it's interesting in the context of this thing that we're testing. So, we were giving people oxygen saturation monitors, and I think they're about $90 a go or something for the ones that we're busy giving out, and you never get them back, so they're gone pretty much.
Yeah.
To use this SDK that comes from this Israeli company, it's like about $1 a go. So you can have 90 goes at this SDK thing if the person's got a phone, for the same price as us sending out one device, which you hope then they use, and don't put on Trade Me. It's that sort of kind of interesting question about, or they figure out how to connect the Bluetooth, or do they type it into the phone anyway? There's lots of those kind of things that come together to go, how do you try and keep it as simple as you can? So
part of that is like what the phone, because suddenly you turn that phone into a medical device, and that's where it falls into a different regulation. And so it's like, sometimes that's why these companies do separate devices, because it's easier to regulate and do that side of things than suddenly clipping this onto your phone and turning it into something that's diagnosing. Which is an interesting thing that our regulations probably haven't caught up so much on in New Zealand.
So that's a little bit of an opportunity for us, I think, in the sense that we get to, with the right ethics and right risk management, at least we can test it without having to worry about some of the legalities of it.
Definitely, yeah.
Very good.
I think the wastewater is another really interesting one in that same regard, right? Where, like, what are we going to test for in that capacity, and how long can we sort of keep expanding the scope before people get upset about what we're testing for? Because as long as there's benefits, people will agree that it's a good thing to be testing for. But in other countries, there's been feature creep where you go, well, I don't know if you should be testing for that, but.
Yeah, that feels like this is kind of the biggest part of the iceberg that sits under the water, is that social license question. And so something that's come up recently, so we're busy implementing APIs between the community midwife system and the national maternity system, which is from CleverMed, so it's called BadgerNet. And the thing that's thrown up is the Breakglass conversation. So we've not had a very sophisticated conversation about Breakglass in this country. And so Breakglass exists where it is designed so that if there's an emergency situation, you can get access to the record, you can get access to kind of some part of the patient's record. So, and the use case is obvious. Someone turns up, they're unconscious, we know who they are because we pulled their wallet out and looked at their, driver's license, but we're worried about why they're in the hospital and they're unconscious. Can we look at their record? And so, you break glass to be able to look at their record, and it's common in between primary care and hospital, or between mental health services and physical health services, or in lots of situations where it might be useful. But we've kind of got this binary view at the moment, which is it's either break glass or it's not. And so because Breakglass is a very secure way to collect that information, we've kind of what normally should be 5% of the time, we've made 50% of the time, because we've either got you're the care delivery person, or you're breaking glass. And so we've introduced this massive amount of inefficiency where if you're the patient and you start to look at your records, you're seeing a pile of people breaking glass, and you're like, that wasn't an emergency. Why are they calling that an emergency? And so we're starting to work through if you're going to expose some of the stuff to the public, you actually have to be accurate about the reason that you're providing access. And so, I think about Health One or Health Connect South, Michael, and there's a lot of break glass built into that process. And the reality is, if break glass is an emergency situation, it's getting used a lot in a non-emergency situation. And so it's not an appropriate thing to call a break glass. But of course, all of our standards and documentation have this binary choice of break glass or not break glass. And we have to go back and find out that actually we should be calling it purpose of use. So the international standards call it purpose of use. One of the options is delivering healthcare. One of the options is being associated with that healthcare delivery. One of the options is then kind of break glass. There's these categories of things. Oh, well, maybe we should be doing that. And it's kind of, we've half built the system, the spine system, and these community midwives were going to have to be typing in every time they wanted to see their community, their pregnant woman, the reason they're using the break glass to see the records that they're trying to record. And you're like, this is just insane. But it's kind of that under the water kind of problem that, you need to have some time in the system to go, it's not immediately obvious when you go, yeah, let's join up the data. Let's join up the community midwives with the hospital maternity people. That just feels like the right thing to do. But then you're kind of in this situation where you're going, should we be calling it break glass? Probably not. Especially because in this context, the women do have access to their own records. So there's a product called Badger Notes, I think, which is the woman's portal, which is available. So we'd be directly showing the woman that their community midwife is breaking glass every time they're delivering, some sort of antenatal care. It's just so, yeah. Well. And then, of course, we've got all the sync problems that come with joining up things that weren't previously joined up. So that's great fun too. But I forget why I even got onto that conversation.
Breakglass, is that security?
Yeah, it might have come.
Social license.
Social license, there you go. So there's just one little aspect that we talk about. Someone, I don't know if many of you will know, someone that we've got started here is working on header, and so she's working on some of this stuff. Her name's Carol Barney. So she came to us from Xero, where they've set up the marketplace of apps for Xero. So kind of that similar joining up Xero data with like integrations with other, supply chain management data or whatever it happens to be. And so how do you manage that as it happens? She also was in charge of their machine learning. So their machine learning kind of governance and she specifically asked me, hey, you guys doing algorithm impact assessments? And I was like, oh, you know what you're talking about. That's good. So that was quite good So she started with us as well. And then Robin Whitaker and I are setting up this Te Whatu Water expert advisory group for AI and algorithms at the same time. So interesting question about genomics and at what point that becomes an AI problem versus a just recording the base pairs conversation.
Well, it's, for some people, it has already become an AI problem. Like some of the variant interpretation things have moved into that AI space to triage what variants are actually worth looking at by a clinician and which ones are not. At the moment, New Zealand is still taking a very manual approach to that. Part of that is that we're dealing with a slightly different demographic than that those AI models are trained on, and that is always a big hanging point where the initial bias of the training data sets is going to be very white in genomics for the coming years. So we just have to be very aware of that.
I think it's AI is inevitable in genomics as well. I don't think people will be like counting the base pairs. But I think the complexity of genomics, the integration in terms of the like the social sectors and the social licensing and so on and so forth, everything integrated becomes an AI problem rather than just a base sequence problem. So that's inevitable.
I think that's what we were just talking about with the Breakglass. Like with some of those models, the sort of the understandability takes a big hit, even though it performs lovely, right? And especially if you're looking at different parts of variants for different decisions, you need to be very clear about why you're looking at a certain piece of someone's genome, right? If that's for their cancer treatment, they're probably happy. If that is for you to inform pharmacs buying decisions, they might be less happy, right? And so you need to be...
That's a really interesting thing, because you go, as a country, is pharmac good or bad? And you might argue it's good. It's largely a good, not a bad. But do you want pharmac to make the decision not to buy medicines based on your genome being available to them? And I think you talk to New Zealanders, they go, no, because they'll then make them, they won't make the medicines available. You're like, oh God, so it's kind of a double-edged sword with them a bit.
Yeah, but those are the types of discussions that we will need to be having with communities, and then again sort of show the impact and the benefit that it has for them. Like we need to, like, what does it mean if we were to expose your data to pharmac? Does that mean that you can get a drug that you would normally not be able to get? Then they're honky-dory. If it means that premiums for certain drugs go up 10%, then no, of course not. But yeah, that is something where
we'll take all of the wins and none of the losses things. Yeah. I think that's kind of that's part of the problem when you start to get to that granular level of being able to analyze all of these things. Is suddenly, I want the benefits but not the risks, or the benefits but not the problems, or the benefits but not the costs.
I mean, definitely, the ownership of the data will, people will start claiming, not the community, but pharmac or MedSafe or Ministry of Health, they will start claiming certain parts of it, at least, that the data. So that then it becomes in terms of exposure of that data to, or people analyzing that data becomes again an inevitable situation, rather than saying there is no access to one party or the other.
Yeah, it becomes a society, like, and it's a really interesting thing, because I think this is, when you talk to Māori, this is actually where it already is. Do you know what I mean? This isn't my resource. This is the resource of my whānau. So
it's for future generations.
So we need to be making decisions in that way, not in a individualistic kind of for today kind of conversation. So,
and I think it's a much more powerful approach to take, because it allows you to have those conversations about the cumulative good and benefit of all, which is a far better place to be coming from than, like, what does it mean to you as a person? But I have to run. Thank you for your time, everyone.
No problem. It's good to talk. We'll see you again soon.
Yep. Bye.
Bye.